You're working as a medical officer in an emergency department and you come across this middle-aged individual who comes up to you with a history of fall as well as unconsciousness prevailing after that fall. How are you going to go about and investigate in this particular patient? You must be thinking that you're basically suspecting that there's some sort of neurological disorder that is going on with this patient. We have multiple of differential diagnoses that can match up to this kind of a scenario, ranging from strokes as well as it can be a patient with seizures. So how are you going to investigate and how are you going to start off with your assessment at this point in time? This lecture in particular is a continuation of the previous two lectures in which we discussed the neuro assessments of the individuals. Basically, we're going to look for the signs of the neurological disorder in this particular individual. First of all, you're going to start off with the history taking, obviously. A detailed history is the mainstay whenever we are going to make a correct diagnosis and work towards a definitive diagnosis. We must know how to take a detailed history when we have patients in which we are suspecting some sort of a neurological disorder. Now, the particulars are again very important, which is going to include the age, the gender of the individual, and obviously we're going to start off with the presenting complaints. The course of the onset of the illness is very important over here. We have the features for the acute illnesses on one hand, and on the other hand, we have a range of disorders in which we have the chronic disorders which manifest as neurological diseases over here. So we must know how to distinguish between an acute illness as well as a chronic illness which is prevailing over weeks to months and even up till years. So it's again very important to know the presenting complaints, and obviously you're going to start off with the history of presenting complaints. Then we moved on and we discussed the mental state examination of the individuals and how basically you're going to evaluate the condition of the individual. Again, all of these features are interrelated. We must know how to have the mental status of the individual because that is going to correlate with the sensory, with the motor examination. So all of these are interrelated figures. So it's again very important to get to the mental status of the individual. The coordinations are important, the levels of consciousness, we have to maintain that in our mind. The Glasgow Coma scaling method is the most prevalent method just to know the level of consciousness in the individual, which is basically ranging from a fully awake and conscious individual towards a comatose patient on the other hand of the scale. So this is again very important to when the patient walks in, you just evaluate the mental status of the individual just to get to know the functionality of the problem over here before we work out towards the definitive diagnosis in these patients. So over here today, we're going to start off with the motor examination of the patient. So whenever we name the examination as the motor examination, basically we are referring to the examination of the muscles in particular. And when we say or when we talk about and discuss and explain the muscular activity, basically we are talking about the muscular reflexes, which can be the reflexes that are demonstrated at the patellar level, at the level of the Achilles tendon, and these are the major reflexes that we usually elicit to demonstrate a normal motor activity in the particular individual. Then obviously, as any other examination, as any other physical examination, when we are carrying it out in the medicine, may it be the abdominal examination, the thoracic examination, the neurological examination, specifically the motor examination, starts off with the inspection of the patient. Inspection is when you just evaluate the patient without touching the patient, and you're just focusing on the normal muscular strength, the tone of the muscles, the normal appearance of the muscles, and if you can detect any abnormality at the level of inspection, just by looking at the muscles, if you can detect that this particular patient might be suffering from some sort of anemia, there is some sort of discoloration over the skin, there is some sort of an edematous activity over the skin, or you might even experience by observing the patient, you might experience that the patient is suffering from fasciculations or any kind of jerky movements, even at rest. So whatever you see and you observe in this particular patient, you're going to document it down. This is the mainstay of the neurological examination, specifically when we come up to the patient and when we introduce ourselves, and you start off by just the frank introduction with the patient, allowing the patient to know that you're going to start off with the neurological examination of the entire body. It's going to involve the limbs, specifically the upper limb as well as the lower limb, and even the reflexes are demonstrated at the abdominal level and at the cremasteric level. So you're going to make the patient aware of the whole examination and make him know that why is it important to examine all of these features in this particular patient. The bare minimum is basically the basic criteria for performing the motor examination. So we have four important topics that we're going to discuss over here. First of all, obviously, the muscle atrophy. Now, whenever we use the word atrophy, it's basically referring to the wasting of the muscles. How do we know that the muscle is wasted? It's basically quite a subjective kind of an examination. Inspection, all of the inspection is basically quite subjective and is depending upon the amount of practice that you have as a physician and as a clinician. You must know how to differentiate between the normal and between the hypertrophy. On the other hand, you must know when the muscle is basically suffering from an atrophy, or is the patient is suffering from a phenomena of muscle wasting. Obviously, you would have those multiple diagnoses in your mind whenever you're going to document that this particular patient is suffering from muscle atrophy. That can be a generalized muscle atrophy, or it can be a localized muscle atrophy referring to a particular muscle, referring to a particular limb, or referring to a particular side of the patient. It's again very important to examine the patient in symmetry. You're going to have a comparison of the patient. If you are going to document that this particular limb is suffering, a lower limb or an upper limb is suffering from muscle atrophy, you're going to have a comparison with the other limb, with the other side as well. And the comparison is going to provide a lot of information. So it's again very important to make the patient sit in a comfortable posture. And then again, there should be a proper lighting that should be observed in the area where the inspection is going on. And obviously, you're going to ask for the consent before examining the patient. You're going to have the consent of the patient, obviously. And then the comparison of all of the limbs and as well as both the sides, that is basically a symmetrical examination, is going to be carried out in this patient. Our next step would be to observe the limbs of the individual, and obviously we're going to see and we're going to look for the tone of the muscles in both of the limbs, as well as we're going to look for the upper extremity strength, and then obviously the lower extremity strength would be observed in these patients. Now, whenever we are inspecting this patient, the upper extremities, or on the other hand, the lower extremities, we're also looking for any sort of abnormal movements if we can look for. For instance, it can be the tics that are observed in the patient. Tics are basically the twitching movements that are seen in the patient. On the other hand, we have the phenomena which is known as chorioathetosis. Now, as the name is implying, it's basically the word choreo stands for irregular contractions of the muscles, and the athetosis stands for twisting and writhing movements. So this chorioathetosis is usually observed in the upper limbs. If you look for these features, you can find these features in a lot of individuals, ranging from the upper motor neuron lesions as well as the lower motor neuron lesions. So far we have basically discussed the neurological examination, and we already know that it's very important to ascertain the sensory examination as well as the motor component as well. When we look at the cut sections in a spinal cord, we know that we have the descending as well as alongside we have the ascending tracts. So the history is obviously correlated with all of these features, and we look for the signs. If the patient has a trauma, we're going to look for the signs. For instance, if it is a hemisection, it's going to be a Brown-Sequard's syndrome. If it's going to be an infectious state, for instance, tabes dorsalis, we're going to look for those particular signs. We already know that all of these tracts are basically going through the brainstem, which is acting as a conduit, and that is basically passing on the information to the thalamus, which is acting as a relay station. And then we have the corona radiata, which is passing on the messages to the cortical features. So all of these examinations which are going to rule out the level that is damaged, the level of the spinal cord, either it is the brainstem or either it is the cortical functions that are compromised in a particular individual by any way. It can be even a neoplastic condition, an infectious states, or the traumas that can even relate to these kind of pathologies. Again, when we are going to examine the features for the upper extremity strengths and the lower extremity strengths, we're going to perform the passive movements. The tone is also basically observed passively. And then again, if the patient can perform the passive movements, then we are going to offer him or her the resistance, and the movements are performed against resistance. And then that is going to basically grade the strength of the individual as well as grade the tone of the muscles. So documenting it alongside when you are basically carrying out all of these examinations is very important besides the motor examination. Starting off, we just mentioned the fact that we're going to start off by inspecting the patient, the atrophy as well as the hypertrophy. Knowing the normal criteria is very important over here. Knowing how to distinguish and comparing it with the healthy leg or the healthy side is again very important over here. And then obviously the muscle fasciculations, which are basically the phenomena of twitching that is observed in the muscles. We're going to look for any sort of tenderness and obviously any sorts of signs of inflammation as well, which basically means the rubor, the calla, that is basically the reddish inflammatory conditions which are associated with the tenderness. That is going to basically highlight the fact that it's not an atrophied condition, rather it's the phenomena of inflammation that is giving off the appearance of swelling in this particular individual. The involuntary movements when we perform at rest, we're going to look for any signs of tics and myoclonus. When we say myoclonus, there is an increased tone in the muscle that is observed, and sometimes there is an alternating tone that is observed in the muscle activity, and you have to document it accordingly when you're going to perform the involuntary movements. Chorioathetosis is already observed. It is dysdoidokinesias, chorioathetosis. These are incoordinated movements that are usually observed in a lot of patients suffering from Parkinson's, and even in Parkinsonism we have this particular kind of movements which is known as the pill rolling movements. Now, when we say the pill rolling movements, basically referring to when the patient is performing the movements between his or her index fingers and the thumb as if he or she is rolling some sort of a small object. So this is what even the name implies. And it's again very easy to diagnose these sorts of movements in the patient. During the maintained posture, the pill rolling tremors, as I've already mentioned, it's a sign of Parkinson's disease. It's basically this phenomena, the index finger and between the thumb, the patient is trying to roll an object, and that is basically known as the pill rolling movements, as the name is implying. With voluntary movements, we have the intentional tremors. When you ask the patient to perform or to write something down, he or she has those intentional tremors of cerebellar disease or familial tremors. Cerebellum, as we all know, is an organ that is responsible for coordination and balance. And whenever the cerebellum of an individual is suffering from some sort of a diseased process, an infection or a trauma that is affecting the cerebellar peduncles, the communications between the cerebellum and the brainstem, the final coordination and the balance activities are going to be affected in these individuals. So these patients usually suffer from a phenomena of intentional tremors that is usually observed in these patients. Then you're going to look for the upper limb tone. We basically ask the patient to perform this rapid pronation phenomena. Now, this is basically, as even the diagram is showing, this is the posture that you're going to ask the patient to perform. If he or she fails to do so, you're going to document it down that there is some sort of a problem with the tone of the muscles in the upper limb. So this pronation and supination that is assisted by the biceps, the triceps, the brachioradialis, all of these muscles are responsible for performing these kind of movements. Then you ask the patient to perform the supination of the forearm. This would be an opposite of the pronation phenomena, and this is again going to show the strength and the vitality of the muscles of the upper limb. So this is how you're going to check the tone of the muscles in the upper limb. After that, you're going to ask the patient to perform the flexion at the wrist joint, and obviously you're going to start off with the extension at the wrist. So these are the usual minimal phenomena that is going to assess whether the patient has a normal tone in the upper limb muscles, involving the biceps, triceps, the brachioradialis muscles, involving the muscles of the forearm, as well as the muscles at the wrist. So this is the normal, these are the normal examinations carried out for the upper limb tones. Then obviously the lower limb tone is tested for, and that includes the if there is a decreased tone, that is going to relate to a lower motor neuron disorder, or either it can be a peripheral neuron disorder. If we just go back into the features of the descending tracts that we already discussed, we already mentioned the fact that there are 3 orders of neurons. Starting off, we have a first order neuron that starts off from the cortical features, ends up in the spinal cord. We have a second order neuron which is usually present inside the spinal cord, and the third order neuron that is exiting the spinal cord and entering the target organs. So usually when the patient is suffering from a decreased tone in the muscles, it's responsible for the lower motor neuron disorder, as well as we might suspect that the patient is suffering from some sort of a peripheral nerve disorder. An increased tone is usually manifested as spasticity in the muscles. Corticospinal tract disease is associated with this kind of a spastic disorder. And then we have rigidity that is usually associated with the extrapyramidal disease. When we look at the anatomical features of the brainstem, we know that we have the descending tracts in the pyramids, and the pyramids, if there is any disease process or any trauma that is related to these pyramidal tracts, That is known as the pyramidal disease. Vice versa, we have the extrapyramidal disease processes going on. So the spasticity is usually associated with the descending tracts, which are the corticospinal tracts, the rigidity associated with the extrapyramidal tracts, and the paratonia is sometimes also seen in the individuals, as well as we have the cogwheel rigidity, which is again usually a phenomena seen in Alzheimer's disease in a lot of patients. Now, as the name is indicating, when we say the cogwheel rigidity, it's basically demonstrated when we ask the patient to basically perform a passive movement. It's not an active movement performed in the limbs, it's a passive movement, and the whole movement is having the jerky movements instead. It's not a continuous movement. It is a spastic movement, just like a cogwheel. So that is how the name is implying the kind of movement that we'd be observing in patients with cogwheel rigidity, which is also seen in Parkinsonism or Parkinson's disease. Motor examination also emphasizes on the strength of the individual. This is again a diagrammatic representation of a test which is usually performed. You basically ask the patient to extend the upper limbs and ask him or her to maintain this position. If there is some sort of a problem with the strength of the muscles of the upper limb, after some time, even after 5 to 10 seconds, there would be a slight pronation supination that would be basically noted down in these individuals. So usually the patient's hand are facing downwards, the palms are facing downwards, and if you note down some sort of a supination in this kind of a test, that is indicating that the patient has a loss of strength observed in the upper limb muscles, including the biceps, including the triceps, as well as it can be including the brachioradialis muscles of the upper limb. So this is a very important test known as the pronator drift, performed for locating any sort of a problem with the strength of the muscles. Then you're going to grade the strength in these individuals. If there is no movement, we usually regard it as a 0. If it's a flicker or a trace or contraction, we give a single point to the patient. And if it's a gravity, which is eliminated and then the movements are performed, it's 2 points for that patient. There is movement against gravity, it's 3 points. At level 4, we have a mild resistance that is observed, and 4+ we have strong resistance, and at 5 we have a full power observed in these patients. Now this is a grading phenomena that is usually used for the documentation purposes. Whenever we have these patients of neurological examination, it's very critical to document an appropriate referral for the physicians who are going to look into the matter. So it's again very important that you know all of these grading systems that we usually imply in the motor examination of the patients. Then again, except when we are not using this grading system 0, 1, 2, 3, 4, 5, we can even use these words such as paralysis for a patient who is performing no movements at all. And then we can have a severe weakness is usually when we observe that there is movement with gravity eliminated. If there is moderate weakness, that is usually associated with movement against gravity, but not against mild resistance in these patients. The mild weakness is the movement against the moderate resistance, or even it can be against the full strength that is seen in these patients. So usually if a patient has the strength, he has the tone, we say that he or she is suffering from a mild weakness. It's not something of a critical sort. It's again going to be correlated with the history of the patient. If you're suspecting that he or she is suffering from a stroke, that is basically indicating it was a variety of a milder form of stroke that he or she has been suffering from. The very critical and the very important component of motor examination is the reflexes examination. So, what is the bare minimum that is associated with the reflex examination? First of all, we must know that we have all of these reflexes for the upper limbs. We have the biceps, and then we have the patellar reflexes, and then on the other hand, we have the Achilles reflexes. Now, whenever we are testing for the reflexes of the biceps, we are basically referring to the areas of C5 and C6. The brachioradialis is tested for C5 and C6 again, and the triceps weakness is basically related to the area of C7 and C8. So these are the upper limb phenomena, and these are the muscles that are related to the cervical areas of the spinal cord. Moreover, we have L3 and L4 in the lower limbs, which is basically demonstrated by the patellar reflexes as well as reflexes of the quadriceps over here. The Achilles reflex is basically manifested, and if there is any problem that is relating to the Achilles tendon or the reflex that is demonstrated at the Achilles tendon, it is referring to some sort of a problem at S1 and S2. So these are the spinal cord segments that are correlated to these reflexes that we usually perform in our outpatient departments. The muscle stretch reflexes that we usually perform, this is a patellar reflex that is performed. Now, sometimes when the patient becomes quite cautious, he or she might not be able to elicit, you might not be, as a clinician, be able to elicit reflexes in these patients. So you ask the patient to perform a maneuver, which is scientifically known as Jendresik's maneuver, in which you ask the patient to clench his or her teeth while you're performing the patellar reflex. Then you're going to elicit these reflexes quite easily in this patient. So it's one of the tricks that you can apply clinically while you're performing this reflex examinations. And even there is a phenomena when you are performing the reflexes of the upper limb, you ask the patient to hook his or her fingers like this and ask the patient to pull them apart. It's again one of the kind of Jendresik's maneuver. You perform these reflex movements sequentially in both of the limbs. So this is basically how you start off with these reflex movement examinations. If you elicit a zero reflex, that is an absent reflex. One is for a present reflex, but it is a diminished reflex in the limb. Two stands for a normal active reflex activity in the limbs, and three is an exaggerated reflex, that is a feature of the upper limb neuron or an upper motor neuron lesion in the individuals. As well as if you're eliciting a clonus by performing a reflex activity, that is going to stand for a grade 4 in these reflex examination techniques. Then on, we have a lot of cutaneous reflexes that are going to be elicited. That is basically including the abdominal reflexes, that is shown by A, and then we have the cremasteric reflexes. So this is again one of the kinds of the cutaneous reflexes over here. And it is basically referring to any sort of an abnormality at a level of L1 and L2. Basically, you stroke the medial side of the thighs, and that elicits an upward elevation of the testicle or the cremasteric muscles, or the contraction of the cremasteric muscles is elicited in the individuals. That is known as the cremasteric reflex. Another very important cutaneous reflexes that we can elicit is the Babinski's sign, which is positive in the upper motor neuron lesion. Usually when you stroke the sole of the foot, that is basically going to cause the flexion of the toes. But if it is a positive Babinski sign, that is going to have, you're going to basically elicit a plantar reflex in this kind of individuals, that is basically the fanning of the toes or the extension of the toes that is seen in these individuals, which is known as the positive Babinski sign. The dorsiflexion of the big toe is elicited in these individuals. The cutaneous reflexes, one of its range is the anal reflexes, in which basically you trigger a reflex by a pin, and that is going to result in the contraction of the anal sphincters. Then obviously we have the superficial abdominal reflexes, which are ranging to any kind of an abnormality relating to T9 and T12. So it is done by a pin or any sharp object, and you look for the reflexes in all of the quadrants of the abdomen, and that is basically going to be known as the abdominal reflex or superficial abdominal reflex. The primitive reflexes basically include the palmar grasp reflex, and then we have the rooting reflex, in which you trigger the reflex by the angle of the mouth, and then we have the plantar grasp reflex. So if any of these reflexes are present in an adult, that is an abnormal phenomena, and you're going to document that some sort of a primitive reflex is found in this particular adult individual after a traumatic condition or an infectious state. So this is going to be documented as one of an abnormality of its kind. One of the reflexes is the palmomentalis, which is again one of the variant of the primitive reflexes. The sensory examination basically includes the light touch, which is done by a cotton wool or even the finger of the physician or the clinician. We can perform and we can ask the patient if he or she can feel this light touch or not. The pain can be elicited by the use of a sharp pin. Then we have the temperature sensations, which can be done by using two test tubes dipped at different temperatures, and then you ask the patient if he or she can feel the difference in temperature in a particular limb or in a particular dermatome. Then obviously the vibratory sensations, and then finally we have the joint positions. When we are eliciting the light, touch, pain, and temperature, it is usually elicited not in the extremities, and for vibration and joint positions, we usually elicit that in the extremities, in the lower limbs or in the upper limbs. So this is how you examine this kind of sensory examination. It is carried out. Vibratory sensations are usually carried out by a tuning fork, and then the joint positioning is usually carried out, and then the 2-point discrimination, and all of these features are looked for when you are carrying out the sensory examination in the individual. We know that the pain and temperature is carried by a single tract, that is the lateral spinothalamic tract, that is carrying these sensations in a particular way. We have fasciculus gracilis, fasciculus cuneatus, and all of these tracts have the specific features to carry out, and different sensations are carried by different tracts. So if we elicit any abnormality in any one of these sensory modalities, that is going to point out towards the abnormality of that particular tract that we're going to talk about. And even we should know the level of decussation of these tracts, because that is going to elicit which side is affected. So it's again very important that you should know all of these anatomical features while you're carrying out this kind of a sensory examination. The coordination examination is carried out after that. It is usually done by a test which is basically referred to a finger-nose test. You ask the patient to touch your finger and then touch his or her nose. So that is how you carry out this kind of coordination examinations. And then we have another test which is known as a shin heel test. As the diagram is implying, you ask the patient to touch the ipsilateral or the contralateral heel and then the shin, and if he or she can perform this kind of a coordinated movement, that is basically showing that he or she is not suffering from any sort of discoordination or imbalance. That is showing any abnormality at the level of cerebellum, of course. The gait of the individual is again very peculiar over here, and you look for the signs of walking and turning normally. Even this examination can start off right when the patient enters your clinic. That is going to basically elicit if he or she is suffering from any sort of gait abnormality or not. Then obviously you're going to look for any sort of walking on toes. This is one of the features of abnormalities. Walking heel to toe along a straight line, all of these features are looked for. What are the abnormalities that you're going to look for, and what are these abnormalities depicting is again very important. A decreased arm swing on one side is basically depicting a corticospinal tract disease. A stooped posture or short-stepped gait is depicting Parkinsonism. A broad-based unstable gait is depicting ataxia, which is basically referring to the uncoordinated movements. Scissoring gait is again whenever you look for and you see it's referring to the spasticity of the muscles. Then we have a high-stepped slapping gait, which is referring to the posterior column or the peripheral nerve disease phenomena. And then finally, we have patients that may appear to be stuck in place. So it's again referring to apraxia, which is difficulty with motor planning. So it's another term that is used for that. And it's usually associated with the frontal lobe disease. So you know why is it important? Now you know why is it important to examine and to evaluate the gait of the individuals, because the particular kind of gait in an individual is referring to a particular pathology in that individual. The neurological diseases usually refer to whenever we have any disorders related to the cerebrum, the patient is going to have an abnormal mental status, cognitive impairment. He or she would have a history of seizures. Unilateral weakness would also be observed in these individuals. Sensory abnormalities, when you're going to carry out the examination, you're going to look for all of these sensory abnormalities as well as in these individuals. Will have the visual field abnormalities and the movement abnormalities. So this would be a typical picture of a patient who is suffering from some sort of a cerebral disorder. So this is how you get a differential diagnosis in a patient. Disorders of the brain stem are again very important, and we already discussed and went through the cranial nerve examination. And if a patient is suffering from an isolated cranial nerve abnormality, crossed weakness, or sensory abnormalities of head and limb, it is indicating that there is some sort of an abnormality, inflammatory, traumatic, neoplastic, that is relating to the brain stem of this particular individual. So again, the history taking is very important, and you must know how to evaluate the patients of spinal cord and the root disorders. That would give you a history of backache, tenderness, weakness, sensory abnormalities, sphincteric dysfunctions that would basically be elicited in the history as the urinary incontinence, irradiating limb pain, and as well as these patients would be suffering from loss of reflexes. Then on, we have the patient of peripheral nerve disorders. These patients would usually have a history of mid and distal limb pain, stocking and glove distribution of sensory loss. It basically means that this kind of an abnormality, that is the peripheral nerve disorder, is going to affect the extremities of the limbs. There is going to be the weakness or sensory abnormalities, as well as the patient is going to suffer from loss of reflexes. The NMJ junctions are the muscles. If they're involved, the patient would be having bilateral proximal or distal weakness, increasing weakness with exertion, as well as the patient would be spared with the sensations. He's going to have normal sensations in this kind of a disease. So over here, we discuss the different sort of neurological disorders and how do we get to a definitive diagnosis in a patient who is suffering from a neurological disorder. The final stay or the mainstay would be the lab investigations that would be performed, including the baseline investigations as well as the electrolyte imbalances if they're noted for, and obviously the neuroimaging techniques in which we look for any abnormalities that can be seen particularly in these patients. And then obviously we're going to look for the history as well. Sometimes even the patients with rather grave diseases usually do not have any abnormalities in their labs. For instance, patients with epilepsies as well as with seizures and even the comatose patients would usually come up to you, and you might not have any history at hand. So how are you going to go about and elicit any sort of abnormalities in these kind of patients is again very important. Then on, we look for and we elicit these sorts of examinations, including the sensory examinations, the motor examinations, and we as a clinician must know how to elicit the reflexes properly in a patient. Then only we can have a rather wide range of differential diagnosis, and then only we can rely upon the labs as well as the imaging techniques to get to know to a definitive diagnosis in these kind of patients. So that is the end of this lecture. Thank you for watching sqadia.com.